Okay, first question this week. A really good question, and I just done a podcast for Rugby Renegade actually on this. And what I would say is, if you're an S&C coach, I see a couple of things happen here. I think some S&C coaches almost try to become physios, and then some physios almost try to become S&C coaches. So I think you need to understand the principles of getting strong, getting your athletes strong, but moving well under load. I think some S&C coaches can almost go to movement based. I think it's important to understand movement, but I think it's even more important for an S&C coach to get really good at cueing and coaching your athletes to move well under load. And I think that's one of the best skills that an S&C coach could do. And I think if you can do that, then that's going to put you in good stead. In terms of return to play, I think again, you once you get them lifting well, you get them lifting with good foot pressures, with good movement variability, managing and challenging their base of support, then I think you're going to do a great job with that as well. So I think the first thing is get well or get good at coaching and being able to change how an athlete's moving with just your words. And then start to look at foot pressures. Again, my new book, my injury prevention book, there's a lot in on that, on foot pressures for common lifts. And then also then it's just a case of understanding basic movement. But I wouldn't go too far into forgetting all the core things that you need to do as an S&C coach as well, and become too physio. So with this, I think the big thing that I'm looking for here is, well, to be honest, there's quite a few things. I'm definitely interested in what the calcaneus is doing. So I want the calcaneus to be able to plant the flex evert. And then I want the big toe. And I also want the big toe to be able to extend, but I also want it to be able to adduct. And I find sometimes the flexor hallucis or the abductor hallucis usually has protective tone where that actually and that abductor hallucis will actually attach up into close where the plantar fascia attaches as well. So I get really good results making sure that can lengthen in the frontal plane, which also will help big toe extend. Big fan of IASTM for the plantar fascia, get decent results with that, so I use that a little bit as well with that. So that again is more what I'm talking about there is more getting the symptoms to settle down. And then as always, it goes back to your assessment of why is that plantar fascia maybe taking a little bit more load. So again, I'll be very interested in if the hamstring and the gastro at the knee is doing enough work, if it's transmitting force through the gastro up into the hip, if the hamstring can work isometrically and allow that energy to travel through up into the hip, which it probably isn't if the fascia is taking a little bit too much. So they'd be the main things. Get all that to settle, and then it gets a bit boring for me because it's just go through the step-by-step process of graded exposure. Then where you try to build everything into one, you get everything working together. That's my approach. And as I said, it's just getting the symptoms to settle is usually the hard. I would probably want to, again, without kind of fairmonger, but just definitely maybe check your bloods, rule out any AS issues with this. But yeah, a bit of a tricky one. Sounds like a bit of an inflammatory reaction potentially, but again, probably, to be honest, I need to know more information than that with the person as well. But yeah, just keep an eye on that tailbone pain. Recently I've been messing my back up trying to do a bit of CrossFit, and it's absolutely ruining me. So yeah, graded exposure. I definitely don't practice what I preach, and I'm paying for that at the moment. So I'll put a post up on that. With knee valgus in patella femoral pain, I probably wouldn't really take too much notice of it, to be honest. The way I assess, I don't particularly do single leg squats or anything like that. As an assessment, I don't think it's a movement that a lot of people do naturally, and I think it's a very consciously taught movement. So if someone is valgusing in that, I wouldn't pay too much attention. What I'd be interested in looking at is looking what happens right from the foot up into the hip. So again, I would probably be starting with my approach on the bed and seeing can they get a co-contraction of the knee at that stage, and if they can't tolerate co-contracting there, pushing through the midfoot and actually generating just a submaximal load there, then to me a lot of the stuff that you're seeing up and standing are just going to be high threshold strategy. So I in my assessments I bring it way back, and we build up before we even get into standing. So usually by the point where they're in standing, I wouldn't tend to see too much of that, or certainly I don't pay too much attention to it if I'm being honest. So I don't have a massive opinion on knee valgus. I treat what I see on the bed, and then we work our way up. And I think it's an important position to get into, but you need to be able to decelerate in those positions. So by the time I'm taking my athlete into those positions, or my patient into those positions, they wouldn't have any pain when they're doing those exercises, because I would have started on the bed and brought them through a step-by-step graded exposure. Yeah, really good question, Mohammed. It's getting more popular, this, and I think it's going to become a bit of a buzzword. I don't particularly pay any attention to it, just like I wouldn't pay attention too much to standing posture, to be honest with you. I think we'd have a long way to go before I could say with any confidence that it's going to correlate to a couple of things. What I'm finding really useful with telehealth is actually just looking at the excursion of the ribs. So getting to see, is the person's ribs able to elevate, externally rotate and widen that angle, and then as they exhale, is it able to come in? But then most importantly, is the rib cage able to retract? Because again, the retraction of the rib cage is probably the most important thing in the exhalation. So for mentorship, if you want to use that stuff, then in theory you could spend a little bit more time around the obliques with a wide angle. But then in theory, with a narrow infrasternal angle, you could hypothesize that you might want to desensitize the external obliques to allow that to lengthen. So I think in the mentorship, we're hitting it anyway. So I don't particularly think it's going to need any special attention to what I'm doing or anything like that. So as I said, I think it's more if someone can't actively mobilize through the ribs, then let's just get everything moving. And then the last little bit, if we need a little bit more internal oblique, you're going to get a lot of that with nasal breathing anyway, where the internal obliques are going to be able to work a little bit more without the external obliques overpowering. So I think it's a buzzword. It's going to become more popular with people, but I think the way we look at the tissues and just focus on helping them go through full range of motion, then I think that's kind of hitting everything anyway. I don't think I need to specialize for one angle or another. So for this one, I think you probably need to do all of your rehab off straight line. So again, if your foot is facing straight ahead, so if it's your left foot and your left foot's facing straight ahead, I'd want your pelvis to almost be facing 3 o'clock. So that would take load off the lateral side. It just let the symptoms settle a little bit. And then the big thing for us is finding what's not doing its job. Again, that could be from the knee down. It could be from, it could even go up into the rib cage. Unfortunately, one of my pet hates is giving advice to people without actually knowing the injury history. Because again, I don't practice what I preach when I train, but I do practice what I preach when I try to help people. And it all starts with the subject. It all starts in understanding the injury history and the timeline. For me, I need to understand that, and then I need to understand what's going on with the subjective assessment as well. So sorry, I can't give you any more on that one. I do a good bit of soft tissue as the obliques attaching to around the inguinal ligament as well. And then when the person extends, what I'm looking for here is ribcage elevation and the pelvis to anterior tilt. That would show me that the tissues are lengthened. And then I just want to make sure that the trunk's rotating quite a bit. And then obviously as always, we want to find out why, or certainly have an idea of why those tissues were overloaded in the first place. When they get back in the gym, I'd want to be making sure that, especially when they squat and stuff like that, that they're not massively extending too much through the trunk again. So again, when someone's stressed, we tend to go into that typical kind of posture. So again, that's going to put those tissues in a length tension relationship. And then it's just about getting what's not doing its job, and getting that to do its job really well. Make sure the rib cage can go through 3 dimensions, and build them up through graded exposure